Hello, my name is Robin Weinstein, and I am an associate professor and chair of human resource management programs at Wilmington University. And today I'm also speaking from a different hat that I have, where I'm the founder and president of a nonprofit called the M25 Initiative. And during today's presentation, I'll be talking about an examination of the results utilizing a collective impact housing first model to end chronic homelessness in a rural setting. And so we'll be talking about the successes and challenges of collective impact and housing first in that rural area. So to begin, the Cumberland County Housing First Collaborative what is a unique consortium of social service organizations, faith-based institutions, and government officials that were organized for the goal of ending chronic homelessness in Cumberland County, New Jersey, in the United States. Cumberland County is the poorest county in New Jersey within the United States there. And so the idea was, can we get all the different nonprofit partners, the different government institutions, the churches, volunteers, grassroots effort, can we mobilize everyone toward toward one aim of ending chronic homelessness through a model that would be both cost effective, because collective impact, the idea is that we wouldn't be recreating services, but taking the services that are found in different agencies and harnessing them to address this problem of chronic homelessness. And so could we have a cost savings model, and can we also do this successfully working together toward one aim? So the goal of this paper is to give an overview of the collective impact process, the procedures, successes, and impediments in this collaboration, which had the goal of ending chronic homelessness by 2020. It is now 2021, and we have housed our 100th individual. But one of the things that we will note throughout this presentation is that the pipeline for homelessness, while we were able to triage homelessness, we aren't able yet to prevent it. And so therefore it creates this cycle of chronic homelessness. This will examine preliminary data that supports previous studies that housing first models do save public and private money while improving health and wellness outcomes for clients. So first, to understand chronic homelessness from the U.S. Department of Housing and Urban Development, their definition is a chronically homeless person is someone who's been homeless with a disabling condition for more than a year, or they also have this idea that you can be an unaccompanied individual with a disabling condition that you've had 4 episodes of homelessness in the past 3 years. So one of the interesting things is going through this process is, how do you document someone who has been homeless 4 different times throughout the year? What kind of documentation is involved with that? But we wanted to address chronic homelessness because they're really the tip of the iceberg. They're really the hardest population to house, because the longer you are homeless, the more likely it is that you will stay homeless. The more that you're homeless, the more likely you will develop mental and physical illnesses that will also keep you in this cycle of homelessness. And so we're talking about individuals that have a disability. They've been homeless for a long time, and how do we get them stabilized and in a place called home? So housing first, and I'm going to make sure that the PowerPoint is attached to my presentation page, because within the PowerPoint, in the notes, you can see the full literature review for each one of these concepts. But I just want to highlight here that housing first is a relatively new program. It was first introduced in New York as an intervention for chronic homelessness, and it gained popularity throughout the US, Europe, and Canada. And basically, this is what housing first the philosophy is. It's taking someone that is homeless and putting them in housing first, then building the wraparound services around that person once they've been stabilized in housing, recognizing the uh, the psychological, the physiological need for housing, for that safety. When we think about Maslow's hierarchy of needs and so forth, is making sure that those basic things are in place for people's health and safety, and a place called home is necessary for that. And then what we do is we build those wraparound services, but it's done not in a punitive way, whereas if the person doesn't do the wraparound services, then they're going to get kicked out of their housing, but rather it takes the approach of coaching the individual to develop their plan of action to get back on their feet, and providing the services for that individual so that they have ownership over this process. But important to understand that they don't get kicked out of the program because they didn't uh, follow through with their program. But if they continue to pay rent and follow through with their lease, they get to stay in the program. So housing first, it saves lives and it saves money. In 2012, the U.S. HUD Secretary estimated that a chronically homeless individual costs about $40,000 a year to the system. And that is government, that's nonprofits, that hospital systems, EMS services, jails, police services cost about 40,000, because what ends up happening is a person who's experiencing chronic homelessness finds shelter in jails and hospitals, transitional housing, whether it's a hotel or motel placement, and sometimes they end up in an emergency room for a visit. And they are quickly discharged, but they find out that they can get a meal in that emergency room. And also, sometimes they end up in a psychiatric hospital. But you see just from on the screen here that housing first really does save money and has been seen to save money. And we'll see that in this study as well. So a little bit about Cumberland County and this Housing First Collaborative and the M25 initiative. So the M25 initiative was actually birthed out of the Cumberland County Code Blue program, which was a grassroots initiative to shelter homeless individuals in church buildings during the cold winter months. At that point in time, we recognized how many people were homeless in a rural community. It's hard to see homelessness in that rural setting. So when you bring them all together, you see it. What can we do to address it? In 2015, it was estimated by all the studies that there were 60 chronically homeless individuals. We now know that that number is incorrect, because to date, we have housed over 100 people, and this study will look at the first 92 people, and there's still more people in the pipeline. The hospital center in 2015 noted that they served 107 homeless individuals through the emergency department and behavioral health unit. Those individuals had 662 visits in a 12-month time frame. The average number of those visits per person was 6.2 hospital contacts, with the highest number of visits being 25. So these individuals are utilizing the hospital services to triage common things that somebody might go to a family physician or an urgent care type of provider. They're utilizing the hospital system for more than it was designed for. Chronic homelessness also causes a strain on the public safety system. The county jail, on the average, sees 8 to 10 inmates every quarter, or 40 annually, who are people that are homeless. They see the jail as an escape from the street and a place to find refuge. Maybe they throw a brick into a window there, but just to get shelter from the overnight hours. So the M25 initiative, the nonprofit that was created out of the Code Blue program, we talked about this idea of, can we use collective impact to harness the strengths of all the respective agencies in the community to focus on chronic homelessness, to work together rather than being in competition with one another toward a common goal. Collective impact is this idea that we can create large scale social change by just coordinating with one another, by talking with one another, by working with one another. It is easier said than done, and as I'll talk about later on. But again, in the PowerPoint, you can see the literature review on collective impact, the successes and challenges that have been noted in the literature there. If all parties buy into it and how you get them to constantly buy into it, then it does work. But one of the things that we notice is that while collective impact started off strong, it kind of waned off as the funding for each one of the partners waned off. They weren't necessarily incentivized to keep at the same level of engagement. So, as mentioned before, the Cumberland County Housing First Collaborative is utilizing this collective impact model. The collaborative is guided by the agency that I'm the president and founder of, the M25 initiative. And the idea of the M25 initiative is to raise money for projects such as Housing First, projects such as Code Blue programs, to facilitate grassroots efforts and efforts of agencies to work together to address chronic homelessness. And you'll notice that within the list of the partners for the collaborative, there are a lot of different groups that are made up of different ethnic backgrounds, different sizes of the organizations, different geographic territory. But at the end of the day, they were all focused around this idea of how do we address chronic homelessness by making sure that we are routing individuals to the appropriate partner that has the appropriate set of funding for that individual. So the primary goal of the Cumberland County Housing First Collaborative is to end homelessness in Cumberland County, starting off with the chronically homeless and then moving up, providing the appropriate supports, stabilizing the living situation, and again, work on that wraparound case management service to improve mental and physical and even family health outcomes there for those people that are suffering through chronic homelessness. So how we identify people is that those applicants or their providers complete an online referral form via our website. Paper referral forms were also located at those warming centers where in those church buildings where the Code Blue program was operating. Participating churches had them, case management programs of all participating providers. And how it initially worked is we were awarded vouchers from the state of New Jersey, 5-year vouchers, which are in the process of being renewed, that allowed those people without with an income to be able to be housed based on a small percentage, approximately 20% of their income was utilized for the rent, while the voucher covered the rest of the rent. The remainder of those individuals were covered under rapid rehousing money that was privately raised through the M25 initiative and partnerships with the hospital system. This idea is utilizing community partnerships and volunteers. Every individual would be sponsored by a group, churches, families, so forth, that would move that person into a place called home. And so that way it would also provide an opportunity, a connection for community and a connection for ongoing relationships. So we would have these welcome home parties, uh, and it would be a community effort to move individuals into their home. We also made sure that individuals are provided with financial literacy, guidance on setting health outcomes, mental health, and counseling services through the different partners that we have. So let's get into the results that we have seen up until November 2019 from the start of our program. So at the time of doing the data collection in the data pool, we had 92 individuals housed. As I mentioned, 36 voucher participants, and I apologize, I misquoted it. Clients pay up to 30% of their income toward their rental payments. Most of their income comes from Social Security disability payments, because again, they would find themselves having a disability. Part of the process of going through this is making sure that they are getting the benefits that they are entitled to, including disability income. But the disability income gets many times tied into one's ability to have a mailing address and driver's license and all those things which are ultimately connected to having a residence. Then this study looks at 56 rapid rehousing participants, and that was private money, where we would take clients that would receive up to $2,500 in rental subsidies. So clients would have to be able to support themselves beyond that $2,500 rental subsidy, because that would really provide first month's rent, last month's rent, so the security deposit and assistance in moving in there. And what we have found is that we have an 88% retention rate in housing after 1 year with all of our clients. So looking at the data, we looked at the hospital data. When we take in a potential client, we look back 3 years at what their hospital utilization has been. And then we track it from the time that they're housed to the time of the data pool. What we have seen is a dramatic reduction in our clients. So the phase one clients were the individuals that received the voucher. And those would be people that really didn't have much income. They were, again, that tip of the iceberg, the hardest group. They had vouchers. 35 individuals prior to placement of the people that we house, of the 36 in phase one, 35 of them, you'll see in that 3-year look back, had over 1,000 days in the hospital with 903 claims. Now we use the figure from that is published through the state of New Jersey for what is the average rate for a nonprofit hospital for visits and claims, and that is the figure that we utilize to put in here to extrapolate what the estimated cost is for the hospital system. So you'll see that it was $2.9 million in claims just for those 35 individuals, and that would be claims that would be covered under federal programs, Medicaid, and charity care, and so forth. Once we house the phase one individuals, you'll see the dramatic reduction that first only 31 of those individuals went back to the hospital for visits. But you'll see the day count dramatically reduces, and the visits and claims have a reduction as well. And these are the total days, but we see a 60% reduction there. Then the phase 2 through 4 clients, those are the individuals that receive the rapid rehousing. And you'll see that now those clients have, they don't have all the pre-existing conditions of the phase 1 clients that have no income, because obviously phase 2 through 4, they do have some sort of income there, though they still meet the definition of chronically homeless. We see a 90% day reduction in their utilization. And so the approximate savings to the system just for healthcare is $6.2 million from the time that we started the program to the time that we did the data pool in November of 2019. It's a 23% reduction in individuals utilizing the Inspira services there. So one of the things that we looked at the per day utilization factor. Obviously, people didn't move into their homes on the same day. So we took an average of the day count and divided that over the 3-year period look back for the phase 1 prior placement. And then we did that for once we did for during placement, you'll see that we did, again, the average of 443 days and divided that over 2 years. So it's a total of 443 days divided by 2 years, which would be the average of the phase 1 clients being housed. And the utilization reduction holds still there, that there is a significant reduction. It goes down to 0.38 and 0.32 for visits and claims. So from an 82% visit claims to 32% once, or actually from 82% to 50%, with a 32% reduction there in visits and claims. And that trend also continues with the phase 2 through 4 placement. Again, their average stay in a house once we got them housed was 12.43 months. We took the total of 133 days and looked at that as well. And again, you see a significant reduction. Prior to placement, 0.73, and after placement, 0.32, with a difference in 42% there for the reduction. So we expect these trends to continue. One of the things that we'll talk about is that as we look forward, we have to continue to pull out the longitudinal data to see, do these trends continue downward. We also know one of the things that we're going to look at for future research is that the age of our clientele, the chronically homeless, tend to be older, and so then they end up requiring more services in the hospital. But one thing that we see is that the day count is being reduced. So while they may have a visit, they aren't necessarily staying for multiple nights there. We also see the decline in the trend in the jail stays. So of those 36 clients in phase 1, 16 of them had been in jail during the 3-year look back. They had over 1,000 days total, and taking the average cost of the jail stay in New Jersey and multiplying that by that count, you get $155,581.20. Once they were housed, look at this is amazing. Only 6 individuals ended up going back into the jail at some point in time, and only accounted for 52 days. So again, a significant reduction of 983 days, and $47,764 a reduction in savings there. And our phase 2 through 3, notice that only 7 individuals were in jail prior, only 1 returned back. And so the reduction goes down from 410 utilization to 555 or 55 days, excuse me. So we have significant reductions between phase 1, 2, and 3 for the jail stays there. So one of the things that we want to look at are the super users, the 30 and these are people that had 30 or more hospital days, that say 30 more hospital days in that 3-year look back. So when we look at super users and we look at their age as well, so super users 50 and over prior, uh, they had there were 11 individuals. They consisted of 900 stays or 900 days in the hospital, and their visits and claims 766. You'll see that the super users make up a bulk of those the hospital costs. Once they got into housing, only 10 individuals went back, but notice the day count drops to 74, and the visits and claims even dropped significantly there. We had a reduction of 92% in the total days and visits and claims from the 3 years prior to the 2 years that they have been housed. Super users under 50, there were only 7 individuals that were under 50 there, and they had 651 days and 366 visits. Once they got housed, only 5 individuals returned back, and again, a reduction of 74% of their day count there. So super user days and cost reduction, it had was 1,316, a reduction there. That gives us a very hefty savings of $3.6 million just on the day count alone, and visits and claims 1.6 million as well. And taking that same idea of the per day utilization, looking at giving an average for the super users of 16 months in housing, you looking the fact that they would have 74 claims and day counts, you'll see that the reduction there goes from again, we have a 67% reduction and a 56% reduction in visits and claims. 67% reduction in day count, 56% reduction in visits and claims. Super users under 50, again, we see another reduction of 33% and 14%. But again, with the under 50, you even see this reduction of how many end up going back into the system, back to the hospital there. The total utilization day reduction is significant there. So wanted to take a look at one of our clients as a case study. So this individual had been in the Code Blue program. He had been homeless for 7+ years, and he was moved in to his home in 2017, in June 2017, and there he is in the lower corner getting moved into his home, and the group that sponsored his move-in at the top right-hand corner. So since 2014, that individual had 78 visits. He had in the hospital. He had 86 days, overnight stays in the jail. Once he was housed, he only had 2 visits to the hospital and 0 days in the jail. And the hospital visits were for a true medical condition. So we see there that someone who had multiple stays, had a long history in hospital and jails, didn't go back once he was housed. Just that individual alone, when you look at the hospital reduction and the jail reduction, you'll see that it's close to $120,000 just for that individual. And when you consider that the voucher is about, and the Housing First model is about a $12,000 model per individual, $12,000 to place them in housing, versus the system that costs everybody approximately $120,000 for this individual. There's a savings to the system, savings to the taxpayer, savings to nonprofits, but more importantly, it saves lives and it changes people's perspectives and gives them a fresh outlook. Now, some of the challenges that we've had with this is the collective impact management. How do we get people to work together? People always wanted to vilify one another. They always want to make enemies of one another. The nonprofit world is the world of competition to compete to get grant dollars. Early on, we had more grant dollars to give out to the nonprofits to keep them at the table. So while they'll say that they're at the table, to keep them at the table required the money, and it also required intensive management from myself as a volunteer, not really having the not having full-time staff and so forth, but really having to push it with all the nonprofits. It requires a collective impact manager, and indeed, the literature points to that you need one person to kind of be the cheerleader, one group to be the kind of the cheerleader to get everybody together. The idea, how do you keep effective communication rather than just sending emails, making sure that people are picking up the phone and getting things done. The challenge of data collection, because data is found in different places, different points. Again, that idea, how do you quantify somebody who's been homeless for 4 years, 4 episodes, and you have to collect that data, and then how do you get everybody to share that information, is a task in and of itself, and everybody's using different systems. So how do you collect that information? In our model, we use things like Dropbox and Wufoo forms and Google Docs to create a shared mechanism there, but it was difficult, continues to be time consuming, but really that is one of the challenges of collective impact. Also funding. How do we keep the focus on the chronically homeless? How do we fund the nonprofit providers that are around the table to keep them at the table there? Community engagement, making sure that the community was aware of the successes of the program, getting them involved to support the program, to move people in, to give money. A lot of our donations are grassroots donations. So that is the ongoing challenges. In order to keep people at the table, you got to keep the community engaged. And we also have to have the funding. So it's engagement, funding, and communication there. And then the longitudinal data collection, as I've said before, we look back and we can see that we've had significant reductions in utilization of jail and hospital. But how do we go from there to make sure that this is ongoing? And this is a weakness in housing first models everywhere, is because it's somewhat of a relatively new model. Do we have enough longitudinal data to be able to say that this works in the long haul? So for more information, I want to encourage you to visit us on the web at www.endhomelessness2020.com. My information is also on our the webpage here, and I look forward to hearing from you. And thank you very much for your time and attention today.